What should we be focusing on? Is it the testing? Are the testings right? Or do we need to try and figure out what medicine works against COVID-19?
I think it's a mix of both. You know, people are probably tired of me harping on testing, but I think it's absolutely the underpinning of everything else that we need to do. So while we're getting better with testing, we still have a long way to go, and we really need to keep laser focus on that. On the medications, we're seeing a lot of progress. We're seeing vaccine progress, which is great to hear because that is going to be a key to long-term fighting of this disease. But again, a lot of ways to go.
What do you find the most reassuring and the most concerning about testing? How much more testing do we need in the U.S., and are the tests reliable right now?
The point-of-care diagnostics are getting better, and they're getting picked up more broadly. We still have major issues with the supply chain around testing, so we still need the reagents, the materials that we need to run the test. We still have issues with the swabs that you use to take a lot of these tests. And
sorry, Lauren, go ahead.
Sorry. We still need the reagents, we still need the swabs, and we still have to focus on making sure that we don't just have enough tests, but they're in the right place. Because the key to reopening and the key to getting back to work is making sure that the tests are distributed in a way that we can detect where clusters may pop up and where new outbreaks may occur.
Lauren, let's go to your core competencies, which is emergency medicine. Okay, so we're going to have emergency rooms in May, in August, in October across this nation where people are going to walk in the door because, you know, afterthought stubbed her toe or somebody broke an arm, et cetera, et cetera. We're going to test all those people for the virus, aren't we?
That's the hope, so that we can move them into the hospital and get them the care they need without putting them at risk, putting our other healthcare workers at risk, and putting our other patients at risk. So the idea would be as people who don't show symptoms of COVID-19 come into the hospital, we would put them in a different part of the hospital and still be able to safely care for them while we're caring for COVID-19 and while we're still dealing with having COVID-19 out in the community.
Well, you know, I look, Lauren, at this and, you know, the huge challenges. I'm right here by Mount Sinai on the Upper East Side in New York, and you can just see it in the faces of the people. Are we going to end up with 2 emergency rooms, 2 hospitals?
I hope that we aren't. I think we can't distribute our clinicians like that. We can't distribute our resources like that. I think we hope that this will become a disease that we can manage with tools like we have for other diseases that make people really sick, like flu, like HIV, like a bunch of different diseases, where we can find people who have it early, safely care for them without putting others at risk, and that our supply chain and our resources allow for that.
We're going to continue here, Lauren. You know, I look at all that's going on in the virus and, of course, the sadness here of 58,000 deaths as well. And, you know, we make an historical note, the same amount as we exceed those killed in Vietnam as well. Give us a scope and scale at the Johns Hopkins University right now. Can we say that you look forward to a May that will be improved from April?
I do hope so. I think we're seeing a slowdown in our cases, and we're starting to feel that pressure release a little bit, but that's the time to be vigilant and not let our guard down, because we will see spikes in cases, especially as people relax their social distancing practices, as they try to go back to work, as they, you know, just get tired of being at home and make different choices. So we have to remember that just because we're seeing that slowdown in cases doesn't mean this is over, and doesn't mean that we suddenly have a toolkit full of tools to fight this. So we have to be protective. We have to follow those social distancing still, and it does get hard. And I think we have to remind each other that it's still really important.
Lauren, there are 2 things actually that I think a lot of people will be worried about. So first of all, we don't know if people have antibodies, and if they have antibodies, they don't know if they can recatch it. And the fact that we also heard that this could be recurring every year, a bit like the flu, but much more deadly. Your thoughts on both?
Yeah, with the antibodies, I think it's important to note that people can get disease and not show antibodies, and they can not. We have a lot of tests that we're not sure how well that they're detecting antibodies. So the two key pieces are to improve those tests so that we know when someone is recovered and if they're developing antibodies, and do some studies on how people's antibodies develop to this disease, and that includes a lot of identification of asymptomatic cases and things like that, but it's going to help us with a lot of our vaccine work. And, I think that we don't have strong evidence of reinfection, but we don't have a ton of evidence against it, so we have to make sure that, we're doing the studies to look at, are people getting reinfected, or are they just shedding that virus for a longer period of time than we realized?